Let's get going. Hi, everyone. My name is Jen Chambers. I am the Assistant Vice President of Lifelong Learning at Duke Alumni Engagement and Development. I am delighted that you are here with us today. This is the fourth and final session in our Forever Learning Institute topic on wicked problems, where we were looking at really complex problems that affect society at large. These are often topics that have lots of different answers, but the challenge with them is that one answer often causes another problem someplace else. So quite complex areas to discuss in this particular theme. I hope you've had the chance to see some of the other topics within this session. If you haven't, they are all shared on our YouTube page, which we will provide to you at the end of the session today and also in the follow-up email. So for today's session, I am delighted to welcome Stelfanie Williams, who will be moderating our session today on building thriving communities. Stelfanie is the Vice President for Durham and Community Affairs. She's been back at Duke for 3 years. Just prior to this role, she was at the Community College, Vance Gardner Community College out west, and was named in 2018 the President of the Year by the North Carolina State Board of Community Colleges. She did her undergraduate degree at Duke in Public Policy and Spanish, did her master's degree at Western Carolina, and her doctorate in education from North Carolina State. So for today's session, she's going to be introducing our first panelist and telling you a little bit about the work that she does here at Duke. And with that, I will turn it over to you, Stelfanie. Thanks.
Thank you very much, Jen, and good afternoon, everyone. As was mentioned, I'm Stelfanie Williams, Vice President for Durham and Community Affairs here at Duke and a Duke alumna, and I am delighted for this opportunity to be here with fellow alumni, colleagues, and friends, and to serve as moderator for this discussion about issues that impact communities at every level. Today's topic is building thriving communities, with a central question of how can we help build communities where everyone can not only survive, but thrive. Today, we'll hear from faculty experts who are addressing issues related to community, such as food security, housing, and migration. Before we get started, I'd like to pull a few slides regarding Duke's involvement at the local community level. The mission of the Office of Durham and Community Affairs at Duke is to forge purposeful partnerships with our neighbors to improve health and well-being in communities. This mission reflects the charge within Duke's strategic framework to forge purposeful partnerships. And the mission is reflected in the recently published Duke Strategic Community Impact Plan that includes 5 focus areas, strategic priorities represented on this slide, as well as corresponding goals. Concurrent with that planning effort, a Duke Board of Trustees strategic task force entitled Duke and Durham Today and Tomorrow met for 1 year to explore past and present efforts and to consider a strategic direction for university community engagement. All of this to support partnership among community members, collaborative faculty, staff, and students, which is instrumental in addressing root causes of inequity and economic mobility at the local level by strengthening the relationship between Duke and Durham and the region. Next slide, please. Durham, like other cities, has challenges and opportunities. 14% of Durham's 320,000 plus residents live in poverty. And we know that these federal definitions of poverty underestimate the challenges working poor residents and others whose basic needs are unmet face, and that these inequities are evident in access to resources and life experiences, and it's reflected in things like life expectancy. On the next slide, we see that there are disparities in housing, with lower home ownership in Durham than the state average and higher rates of eviction. And on the next slide, we note that food access and security are layered and concerning issues affecting our local community. And while the rates of adult obesity and diabetes in Durham are better than the state average, The prevalence of these diseases in under-resourced communities and the effects of preventable diseases on quality of life are unacceptable. And of course, these factors are all interdependent. As we pull down the slides, I would note that Duke's community affairs efforts take a multi-pronged approach to these issues, centered on partnership with neighbors, organizations, and local leaders. Research, service, and funding are combined toward developing solutions. Today, we have 3 experts who will address topics related to building thriving communities, including research, programs, and services. And at this time, I'd like to invite the panelists to introduce themselves and to provide background on their work, beginning with Hardy, followed by Donna, and then Norbert.
Thank you, Dr. Williams. Good afternoon, everyone. It is a pleasure to see so many of you and some very familiar names on the screen. My name is Hardy Vieux, and I am a Duke alumnus, class of 1993 from the Trinity School. And I'm based here in Northern Virginia. I work in Washington, D.C. at an organization called KIND, Kids in Need of Defense. KIND is an organization about 14 years old, started by Microsoft and Angelina Jolie to serve unaccompanied children who've arrived in the US looking to stay here permanently, having fled some sort of tragedy or persecution at home. I serve as KIND's chief of staff, so I basically work very closely with the CEO on everything, legal, policy, operational. Prior to joining KIND this past May, I was at Human Rights First, another nonprofit also based here in DC, doing refugee and asylum work, where I managed the legal team that represented asylum seekers. So I've been in this world for about 10 years now, and I'm happy to say that Duke helped me get started here. It was my midlife crisis when I was about 40 years old that I made this pivot, and with the Duke's help, the Sanford School's help specifically, I ended up moving out to Amman, Jordan, and working with Syrian refugee children, and focusing particularly on their child protection needs. So I come to this work from that background. I'm going to talk specifically about refugee resettlement. Although I do not work at one of the 9 organizations that does refugee resettlement in the United States, I've been privy to the work that these organizations do, the very good work that they do, and oftentimes in partnership with members of the local community. So when it comes to refugees, as many of you likely well know, the United States has long accepted refugees fleeing persecution or war, from taking in hundreds of thousands of Europeans displaced by World War II to welcoming those escaping communist regimes in Europe and Asia during the Cold War. So we have a legacy of this. And for the longest time, the United States did this in a rather ad hoc way. But in 1980, Congress put in place a federal law that sort of organizes how we deal with refugees and how to think about providing them the necessary protections that they need, because they're often some of the most vulnerable populations, and also put in place a system for identifying, vetting, resettling refugees that we still use to this day. I'll say more about that. The size of the refugee population in the US has long fluctuated. But what we saw with the war of Syria starting a few years back is that there was a tendency among policymakers in the United States to welcome in more refugees. And we saw that beginning with the administration of President Obama. The last administration very much focused the spotlight on national security and refugees and the question of, do refugees make us somehow less safe, was very much at the center of the policy debates here in DC under the last administration. And so we saw a restricting of the number of refugees that were in the United States. But before I get more into those numbers and the process, let me just tease out a little bit on terminology. I suspect many of you have heard the phrase migrant, you've heard refugees, you've heard asylum seeker. Let me specify what they mean, because it matters. So a migrant is the umbrella term for people leaving their homes and often crossing international borders, whether to seek economic opportunity or escape persecution. So that's just the overarching term. The term refugee is a term of art, as we say. It's defined by US law and an international convention, the 1951 Refugee Convention that we, the United States, have signed on to. And so that term, refugees, are migrants who are able to demonstrate that they have been persecuted or have reason to fear persecution on the basis of one of 5 protected grounds. Those grounds are race, religion, nationality, political opinion, or membership in a particular social group. So if you have one of those 5 grounds, you could be considered a refugee in international law, and a series of protections come with that. There's another group that I mentioned, that's a group called Asylees. Asylees also are able to meet one of those 5 grounds, the race, religion, nationality, political opinion, or membership in a particular social group. The primary difference, though, is that an asylee is someone who is going to be granted refugee status in the country that they're seeking to remain in, whereas a refugee is granted outside. So I'll make this more concrete. When I worked in the Middle East, I worked with Syrian refugee children. Those Syrians who fled south from Syria, fled north. Actually, they were north of Jordan, but fled south into Jordan. Those individuals were determined by the United Nations to have one of those grounds. And so they were deemed to be a refugee while still living in Jordan. So when they were resettled to another country, like the United States, they came with that international protection already. That's different from, let's say, a mother who is enduring persecution in Central America, who takes her child, flees in the night, and goes north to the US-Mexico border and enters the United States. That person does not yet have any status, doesn't have any legal protection until they've established that they meet one of those 5 protected grounds. So they're an asylum seeker. When they meet one of those protected grounds under the law, then they're an asylee. So why does this really matter? Well, again, it's really a matter of the protections that one gets. Refugees, when they arrive in the United States, come into sort of a really well built out infrastructure as to how to protect those individuals and how to get them integrated into local communities. Whereas asylum seekers are essentially on their own until they get the asylum status. And then also, they're also looking for the ability to work for employment authorization, which is not immediately granted to asylum seekers, whereas it is granted to refugees. So it's really a matter of status, and asylum seekers immediately, they have to apply for that status within a year of getting here. If they don't, that's going to pose a legal hurdle for them. So what we're talking about today is refugees who fall under the umbrella of migrants, but they're distinct and different from asylees. So in this system, as I said, let me go back to the scenario where you have a Syrian living in Jordan at a refugee camp. That refugee is eligible, or that individual is eligible for refugee resettlement by the United Nations High Commissioner for Refugees, the UNHCR. So that agency works across the globe. They are constantly interacting with these vulnerable men, women, and children, and they will make a determination as to who's selected and deemed to be a refugee. Once they have made that selection, and there's a process that goes with that, they're then going to partner with the various countries that they have relationships with to figure out where that individual needs to end up. So they will talk to an individual in Syria. It takes very little analysis to determine that they have fled some bombing and some persecution by the Assad regime. So they're granted status by UNHCR. And now the question is, where will they be resettled? Will they be resettled in the US or some other country? So let's say they are determined by UNHCR to go to the US. So how does that process work? In the United States, we conduct a rigorous vetting process to determine whether to accept a refugee for resettlement. The entire process, start to finish, takes about 2 to 2.5 years. Oftentimes we have lots of background checks and security protocols that really protracts this process. So there are 6 steps in the process. First, as I mentioned before, UNHCR identifies the refugees who will need resettlement based on their vulnerabilities and their specific needs. That's step 1. Second, then that individual will be referred to a country like the United States. And there, the UNHCR will assess each individual, gather all the relevant background information, and submit the case to the country where the person may be resettled. 3, security clearance. So there we have these what are called resettlement support centers, RSCs. These RSCs, combined with US government agencies, start to do a lot of digging, running background checks and security clearance process to determine whether it makes sense and that person, whether it's safe to resettle that person in the United States. That's step 3. Step 4, the Department of Homeland Security conducts face-to-face interviews to determine whether the applicant indeed qualifies for resettlement. Those face-to-face interviews take place in that country abroad. So that Syrian in Jordan at the camp there in Jordan is going to meet with a US government official to do this in-person interview. Step 5 is a series of medical screenings to ensure that they do not have tuberculosis or some other communicable disease, COVID, that will preclude them from being resettled in the United States. And then finally, probably the most important step is that individual now gets matched with a sponsoring agency. So approved applicants are assigned to a local NGO that assists them upon arrival. These NGOs help refugees integrate and become economically and self-sufficient in their community. Those agencies, there are 9 of them that work across the nation that have a relationship with the federal government to resettle these individuals. You may have heard of some of these organizations like Catholic Charities or HIAS, which is a Jewish faith-based organization. And there's another one, the USCRI, which is a Catholic relief organization. So these 9 organizations are the ones that are responsible in our nation to resettle these individuals. And they often work with sort of subcontracts with local agencies in their communities to provide housing, to ensure that individuals get an initial cash stipend when they arrive, to make sure that they have food. So it's a very well built out process. As I said, there are a number of US government agencies that are involved. That includes the Department of State. They have a bureau called the Population, Refugees, and Migration Bureau, PRM, and they're the first point of contact for that refugee outside of the country before they get to the US. The Department of Health and Human Services is involved. The Department of Defense is involved with security clearances, and the United States Citizenship and Immigration Services, USCIS, is also involved. So a number of these entities they work together to ensure that it is safe and it makes sense for these individuals to be resettled in the United States. Once settled in the US, refugees are generally in the hands of these NGOs, as I mentioned, and these agencies, like I said, work with local communities, and there the State Department provides the funding to go towards things like rent, furnishings, food, clothing, and after 3 months, the responsibility shifts from the State Department to the Health and Human Services, which takes on longer-term cash and medical assistance, as well as other social services. So that's the main structure, but these 9 non-governmental agencies really have the major brunt of the work here. During the last administration, a lot of these organizations saw their funding cut off or limited, so they've had to downsize staff rather significantly, but they are still the ones that are very much on the front lines of making these determinations and resettling these individuals. So you might ask, well, okay, what's our number? How many people are we resettling nowadays? As of September 2021, the number of refugees who've been resettled to the United States was about 11,500. For fiscal year 2021, which just ended at the end of September, the cap was 15,000. So from October of 2020 to September of 2021, the maximum that the country was permitted to resettle was 15,000. The new cap set by this presidential administration is now 125,000 individuals. And so far, let me look at my numbers, but I think we're only at a few hundred in terms of the new cap. So this administration is still sort of trying to pick up pace to resettle more refugees. And a large part of that is because the infrastructure was really whittled down in the last administration. And this administration has been very much focused on Afghan evacuees dating back to August. So there's still a lot of work to be done there in terms of meeting the cap. So far, this administration has been focused on resettling about 70,000 Afghans, which had been admitted to the US. Those 70,000 were admitted on something called parole, which is a temporary form of humanitarian relief. So they're not truly refugees in the legal definition, but I'm being really, really persnickety here. But at the end of the day, what really matters is that they're able to apply for work permits and it shields them from deportation from the United States for 2 years. So although they're not technically refugees, these Afghan parolees, they don't count toward the refugee cap. And yet they still have the same sort of needs that refugees have, including financial assistance, job placement, temporary housing, and refugee agencies have had to step in to provide for them. And let me segue to that piece of this. These refugee agencies in the United States are the main places for, let's say you wanted to get involved. If you wanted to support a refugee either in your community or coming to your community, the best place is to get in contact with one of these 9 organizations. And I'll drop in the chat a link to Refugee Council USA. We call it RCUSA. Refugee Council USA is an umbrella organization that works with these 9 organizations, among others. And on their website, you can type in your zip code and it will take you to the local resettlement organization that has a relationship with one of these 9 agencies. And that's where things like greeting individuals at an airport, which really makes a difference when someone's coming to a new country, you can chip in with rent assistance, providing food to those individuals, helping them get jobs, helping them draft resumes, which for many, many individuals in these situations, a resume is something that's foreign to them. So think about it, right? They're coming to a new country. The climate's probably different. The language is foreign to them. The food is not theirs. The school system is different. Everything is different. And so there's a huge reliance on local community members to help these individuals feel at home and help them understand what it means to get settled in this country, to help them integrate. And they also connect these individuals to social services that are really important to help them thrive. So if you wanted to get involved, you can go to the RCUSA website, plug in your zip code, it'll connect you to your local agency that then links up to one of the 9. And of course, you can always write a check. A lot of these organizations really could use financial assistance for the work that they need to do. And so I commend you to the RCUSA website. And if any of you will want to do this sort of work, I'm happy to answer questions later on. Thank you for your time. I'm now going to pass the floor to Donna Biederman. Donna?
Thank you, Hardy. And so I am going to share my screen here and show some slides. But as those are coming up, hello, my name. Oh, I am not here. Sorry about that. I showed you my desktop. So we will try that again. Here we go. Okay. I am Dr. Donna Biederman. I'm a faculty member at the Duke University School of Nursing, and I also am the director of the Doosan Community Health Improvement Partnership Program, also known as DCHIP, where we try to bridge resources at the School of Nursing within our local community. I wanted to talk a little bit about one of my passions today, and that's the Durham Homeless Care Transitions Program, and an area that I have done substantial research and program implementation in. So I probably do not have to tell you this because you see it on the news, but homelessness is increasing. And as you can see, our nationwide homeless numbers are increasing. North Carolina and Durham, it depends on which year you're looking at, right? It's hard to enumerate homeless people, and the way homeless people are enumerated is called the annual point in time count. And I don't want to get too much into that, but suffice to say that these are considered low and very rough estimates. Homeless people are sicker and die younger than their housed counterparts. There's definitely a lot of research in this area. Sometimes the numbers show that up to 20 years younger death. So when we might say the average American, 78, 80 years old, the average homeless person, it's more like 60 years. Because of the amount of morbidity and mortality within the homeless population, there's been this movement towards medical respite. The National Healthcare for the Homeless Council is like the preeminent international voice, for medical respite care. And they've just recently instituted the Institute for Medical Respite Care. But you can see here is the definition of what a medical respite is. These medical respite programs that are across the United States differ depending on the community they're in. Some communities, they're pretty much a full service organization that's very similar to like a skilled nursing facility where there's round the clock physicians and nurses providing care. Some of them are like a hotel or a motel model where people would be discharged to home if they had a home, but they're discharged to this motel for case management services. As of today, on the National Healthcare for the Homeless Council website, there are 116 programs registered in the United States. There are 5 in North Carolina. So why medical respite? What are some of the benefits? Well, as a homeless person is transitioning usually from an acute care, hospital setting into the community, there are some benefits. There could be decreased hospital days, and these are benefits that have been shown through research. Decreased emergency department visits. So for after they've been in a medical respite program after a homeless person has versus before. Decreased healthcare costs. That's a tricky one. And so we could talk more about that. We could probably talk all day about that actually. Improved housing outcomes. And these are just several of the outcomes that I chose to highlight. There is a literature review that was updated actually this year on the National Healthcare for the Homeless website. One of the challenges of medical respite programs are participants leaving against medical advice. There are some rules that apply to many medical respite programs, and I'll talk a little bit about some of those that are germane to my work here in Durham. So about 2013, colleagues and I, there was a grassroots movement in Durham to begin a medical respite program. And we really could not garner support for it, although we knew that there was a need. And so we decided to do a small study about what happens when there is no medical respite program. And what we did with the study, it was 3 focus groups, 18 people total, and we came up with this really crude process map. And I don't really want to go through this entire process map, and it was published, and so it's out there in the literature. But the very interesting thing about it was the timing, because right after we did this study, something happened in Dallas. A homeless man was in Dallas. He had jumped from a height, attempting suicide, and had broken 3 of 4 extremities. He had casts on 3 of 4 extremities, and they wanted to discharge him from the hospital, and he was afraid to leave because they were discharging him to the streets. And so they were reported to CMS for forcefully removing him from the hospital. And all of a sudden, there was a huge CMS investigation in Dallas. What happened was people in the Dallas Morning News contacted the National Healthcare for the Homeless Council and said, what should they have done? What happens when there is no medical respite programs? What happens in other communities? And they said, well, gosh, you should call Donna Biederman and ask her because they just did a study. And it was really very interesting. I was a new faculty member at the time, and this was a very small study, 18 participants, 3 focus groups, but we did get national media attention, which was very helpful actually in advancing our advocacy work. So with that said, in 2014 to 2016, we began a medical respite pilot program. This was unfunded, except the Durham County did provide money for room and board. All case management and everything else was donated gratis. These are my colleagues. I'm there in the middle. This was prior to gray hair. We laughed at this picture today. It's only 5 years old, but boy, have times changed. But, and to my left is Julia Gamble. She's a nurse practitioner. And to my right is Sally Wilson. She is the Executive Director of Project Access of Durham County. We've become quite the team over the years. So for these 2 years, we did this pilot medical respite program. It was very limited, only 20 people referred directly from the hospital, and we provided mostly connection to care. We really weren't providing direct medical care, connection to care and case management. In 2016, we received a substantial grant, the Durham from the Hillman Innovations and Care Award. So it was our second round of funding for that. And we were able to begin the Durham Homeless Care Transitions Program. What the Durham Homeless Care Transitions Program was essentially a program to bridge that hospital to community setting for people experiencing homelessness. We were not providing, and we still do not provide, direct medical care. These are patients that would be discharged to home if a home were available. They have to be willing to engage with us, and they have to be able to follow some of the house rules, which may include abstinence from drugs or alcohol. Sometimes when that presents a challenge for people, we do look for alternate locations. And even if a person does not want to stay in one of our locations because of the need for abstinence, we still engage with them in case management. They have to be competent in their ADLs. And so sometimes, maybe somebody is post-surgery, post-amputation even. And so they have to be able to do their own transfers, able to self-toilet, because essentially they're going to be probably in a place by themselves or with a couple of other roommates, but nobody's providing direct care. They certainly have to be psychiatrically stable, meaning no active threats of self-harm or harm to others, and cleared by physical therapy for home discharge if that was an issue in the hospital setting. So a couple of years passed, and me and my colleagues, again, now aged, applied for another grant. We needed more help with our program, and we received funding from the Kate B. Reynolds Charitable Trust. This allowed us to get a housing navigator for our clients. So we really wanted to take people from the hospital, put them in our respite program for a short amount of time, and then transfer them into their own housing. And this award really helped provide that. In 2019, we received some funding to do an evaluation of our program. The funding, and it's right in the bottom right-hand corner, is through the Duke School of Medicine Opioid Collaboratory, which is being administered by the Duke Department of Population Health Sciences. So what we did is we looked at all of our people that had been in our program over the period beginning July 1st, 2016 through June 30th, 2020, and all of the referrals. And then we looked at people with SUD, so that's substance use disorder, people without, and then we compared those two groups. And so as you can see here, these are just some of our outcome measures that we track, but 96% of our participants were able to obtain a primary medical home or maintain it. More than 95% received medication compliance assistance. We have reconnecting with family and friends. 76.8% of our people are reconnecting. And these are some of the goals that we work with our persons experiencing homelessness that are in our program. The only things that were significant here between our substance use patients and our non-substance use, so these are people that actually have a medical diagnosis of substance use disorder, is those with substance use disorder obtained and maintained mental health care and maintained substance use disorder treatment at a higher rate than those without. And so we were very excited to see that our outcomes were not being determined by whether people had substance use disorder or not. There were no difference really between the groups. When we looked at healthcare utilization amongst our participants, you can see I've highlighted the pre and the post of 3 variables here: admissions, bed days, and emergency department visits. And all of these were statistically significant. But our admissions of 1.63 pre to post, less than 1. Bed days, 16.37. So these are average. And that's the standard deviation following. And then to 5.41, and emergency department visits almost halved. Very excited to see these results and this paper, but these findings is right now in press. So by many measures, I would say that the program's successful. I'm very excited to be a part of it, but there are some points to ponder. And really, who benefits from these medical respite programs? I think, that we could easily say the people who participate in them, but are the beneficiaries beyond that? And then who should fund medical respite programs, particularly in a Medicaid non-expansion states, which really complicates things here in North Carolina. You can see I have some acknowledgements there to my colleagues who I work on this program with, and also to the Duke School of Medicine, the Opioid Collaboratory. So I look forward to engaging in dialogue about this during our question and answer session. I will stop sharing my screen now. And I would like to turn the floor over to my colleague, Dr. Norbert Wilson.
Hi, everyone. Sorry about that. It's amazing. I still struggle with turning on my mic. So my name is Norbert Wilson, and thank you, Dr. Biederman, for that introduction. I'm a faculty member in the Duke Divinity School. I have a secondary appointment in the Sanford School of Public Policy, and I also work with the World Food Policy Center. So I am happy to share some work that I've been doing related to food security. And I hope to engage you in a bit of a conversation around the way that community members have tried to provide support to one another through an interesting intervention called a micro pantry. But to help set the stage, I want to talk to you a little bit about what is food insecurity in the United States, what it looks like, who's struggling with food insecurity, and also I want you to hear from the voices of individuals who are living with food insecurity. So, as many of you may be familiar with the idea of hunger, food security is similar, but it has a particular meaning. Hunger is an idea that typically talks about the physical experience that many of us experience when we don't eat food for a few hours. But the idea of food security has a slightly more nuanced meaning behind it. And what food security means is it's the existence that when all people at all times have physical and economic access to sufficient, safe, and nutritious foods that meets their dietary needs and preferences for an active and healthy life. Notice there's nothing in this definition that's about the physical sensation of missing a meal. It's also not a biological measure in terms of looking for missing nutrients or stunting or wasting. Rather, it's around the idea of a certainty of having access to food. Well, in the United States, we measure food insecurity by using a survey. And forgive me if I flip-flop between the use of word food insecurity and food security. So food security is when you have access to food. Food insecurity is when you have concerns about accessing food. So in the United States, every December, the Household Food Security Module is released as part of a larger survey. And there are other surveys that also evaluate food insecurity, but the national numbers that you'll see me talk about in just a moment is administered by the US Department of Agriculture in collaboration with other agencies. And they ask a series of questions in this larger survey about people's experience with access to food. And the survey is screened so that individuals below a certain income level and who respond to certain questions are the only ones who actually answer these questions. And depending on household characteristics, if there are children in the household, then there's an 18 survey question. If there are no children in the household, they're given a 10 survey question. And I'm just showing you the first 5 questions that appears in both surveys. And as you can see, the questions center around: did you worry about access to food? Did the food not last? Could you not afford to eat balanced meals? Did you have to skip or cut the size of meals? And the questions go on with greater concern about access to food, even to the point of missing meals and even losing weight because of an inability to access food. All of these questions center on the idea of, could you afford to eat or access food? And did you have concerns or worries about not accessing food? Now, I realize this data may be a little bit small, but I want to show you something that's really important about what food security or food insecurity in the United States looks like. And so this is a graphic from the US Department of Agriculture, and it ends in 2019. And this is an important point because I want to talk about what happened during COVID. What we can see is the top blue line represents food insecurity, the prevalence of food insecurity by households. The bottom orange line represents food insecurity with very low food insecurity. And that's a more extreme version of the idea of food insecurity. And it's typically a big gap between these two, thank goodness. And as you can see that food insecurity rose around 2007 and then eventually tapered off into 2019. The reason is because of the Great Recession. Economic instability, loss of jobs are important contributors to food insecurity in the United States, as it is in most parts of the world. One of the things that's important to note about this graphic is that after the Great Recession, there was a long lag. It took a long time for the national food insecurity prevalence to get back down to the 2007 or 2006 numbers. That plays an important role when we think about our current moment. As this graphic as I will talk about in a second, we want to think about the pandemic, but I want to tell you about one thing quickly, and this is something I'm going to come back to in a little bit later, is this idea of differences in food insecurity by household types. We could look at the data in a moment. I will show you some data when we look at when there are children in the household and who's the head of the household. But an important point that I want us to consider is differences by racial and ethnic groups when it comes to food insecurity. As you can see in the top two lines, which are orange and blue, those are African-American or Black households and Hispanic Latinx households. We can see that the rate of food insecurity is much greater for African-American or Black and Latinx or Hispanic households than for white, Asian, and other households. That difference persists throughout time and actually suggests that it gets worse during economic downturns. This problem is particularly one of great concern during the pandemic. And as if many of you have paid attention to what's going on in the pandemic, we know that COVID has had a negative effect on different households based on household types and some of the concerns about employment and work opportunities. During the sort of beginning of the pandemic, after the early shutdowns in March, the government has been running a series of pulse surveys, and it's an evaluation of a number of different factors. One is not food security, but actually an idea that they call food sufficiency, which is very similar to food security. It's a slightly different question. And what we can see is that food insecurity was predicted or estimated to be substantially higher during the pandemic months of June than in the previous time before the pandemic. And this problem seemed to be much greater for Black and Hispanic households. Now, this was taken in June. The food security supplement, the survey that was used to evaluate food insecurity, didn't occur until December. And it actually looks at a slightly different time frame. But this is very important because when the national numbers came in, it showed us something very surprising. And that is food insecurity from 2019, before the pandemic, to 2020, during the pandemic, stayed the same. The prevalence of households that were food insecure did not change in any statistically significant way from one year to the next, pre-pandemic and during the pandemic. And that's even true when we look at the very low food insecure households. This is a result that's rather surprising, and there have been a number of commentators and researchers who've said that the difference has been, well, it's because of the number of payments that came from the government, from the CARES Act and other programs that help provide support to individuals in need. But I do want to draw your attention to something that is important to understand. While the rate of food insecurity did not change from 2019 to 2020, it stayed at about 10.5%. The rate of food insecurity amongst white households actually fell to 7.1%, which is lower than it was in 2019. But for Black households and Hispanic households, those rates rose even greater, suggesting a greater level of disparity in food insecurity in the United States by racial and ethnic groups. Thus, this prevalence or this gap in food insecurity suggests that there is something particularly challenging about food insecurity when it comes to race. Some colleagues and I have been doing some work in this space, looking at programs like the SNAP program, which I'll speak a little bit more about. But one of the things I want to do is move beyond just the statistics and talk about the experiences of individuals who face food insecurity. And some research with Sarah Foltz at Tufts University and other colleagues, we've been conducting a series of interviews to understand the experience and how individuals who live with food insecurity manage their food resources. One of the things that we've heard from our participants is that they are finding innovative ways of meeting their family's needs. So this one participant talked about on Friday is a day when new sales are released, and on every Friday, because I usually look online, is how this person deals with this. I usually try to go and check the sales and go to different markets. You have to work for it, he argued. I never had to do this before. That is before he lost his job. And then another person. Okay, so now during this time of the month, I only get $192 for my food stamps, and they're getting lower. Usually by this time I'm running out. I'm portioning the amount because I think at this time I may have about $60 left. So one of the things, while SNAP is a really important program, it provides substantial support, and there is statistical evidence that shows that SNAP participation actually lowers the rate of food insecurity. One of the things that we found that in some research that I've done with colleagues at Syracuse University, it doesn't reduce the disparities that we've seen, but it also raises some important points about how the SNAP program can be implemented. While SNAP is the major way of providing food security for folks, one of the areas that is really interesting in providing support for families is the charitable food sector. Feeding America is one of the largest supporters of food insecure households, and they did a tremendous job and continue to do a tremendous job during the pandemic. But there is another way that people have been able to meet the food needs of others, and it's this really surprising micro pantry movement. Now, micro pantries existed before the pandemic, but we've seen more and more micro pantries crop up because of the pandemic. And here's just an image of what one micro pantry looks like. If you're a little unfamiliar with those, if you've seen a little free lending library, think of that and that being replaced with actual food products. It's a system where individuals can provide foods and take foods without any concern about providing ID or being concerned of stigma, of being embarrassed about going to this. And they're open literally 24 hours of the day, every day of the week. My colleague, Sarah Folta, and others at Tufts, we did a series of interviews of individuals who participate in the micro pantries and also individuals who help support those. Now, I'll just mention a few comments about individuals who participate in micro pantries. So one person who participated in these micro pantries said that I definitely do worry about not getting enough food. And this is in the middle of the pandemic. Remember, this is also a time when the national numbers suggested that food insecurity didn't change. Well, this is an individual who really struggled. This person went on to say, I can't get around to the big food pantries. Before the pandemic, I still worried. I still had many days sometimes when I didn't have much. I didn't worry as much. I also had a car then. And I also had a job and things weren't so hard. I didn't worry about it as much. And that changed during the pandemic. Here's another person. Honestly, if it weren't for these pantries, referring to micro pantries, during the last 2 months, I'm not sure how we would have ate. I do get food stamps. I get around $350 for a month, but especially with the food price increase right now, that's not enough. And then my daughter's not in school, so that's extra meals for lunch, and it's 2 extra snacks a day that I'm not used to. These are examples of the experiences of individuals who are using these micro pantries as a way of meeting their needs. Now, I want to be clear, the charitable food sector is never going to solve the problem of food insecurity in the United States. There is an important role, however, that community members can provide. And I'm really excited to have an opportunity to talk to you about those opportunities and how individuals like you or I are able to provide support to our neighbors. Thank you for your opportunity to talk.
Thank you for your presentations. At this time, we invite participants to post questions in the chat, but I'd like to start off with a couple of opening questions for our panelists to answer concisely. And we'll start with Hardy. Given the need, Hardy, to assist thousands of Afghans who have arrived in the US since August, could you share briefly, is the US currently resettling refugees?
Sorry, technical issues again. The US has suspended settling refugees. The State Department, Dr. Williams, made clear back in October that given the immense needs of the Afghan community here in the US, that they're going to suspend the refugee resettlement process starting late October through January 11th of next year, with some exceptions. So right now, we've only settled about 500 or so refugees in the United States. Like I said, the main focus is on the Afghan community, and given their significant needs, the government has made the determination that it makes most sense to have the 9 refugee organizations working predominantly on supporting the tens of thousands of Afghans that need to be resettled.
Thank you. And just sort of continuing along in terms of the role of government, Donna and Norbert, could you share your thoughts as it relates to who benefits and who pays? I mean, how much do public service systems or public policy and personal responsibility factor into these community issues? Donna?
I would say that, COVID-19 really taught us a lot of lessons about people experiencing homelessness and health problems, right? Because we do not want a lot of homeless people out with COVID-19 and potentially infecting other folks and people in the homeless community themselves. So I would say who benefits? Society at large benefits from programs like Durham Homeless Care Transitions and Medical Respite Programs. Who pays? Well, I would argue that maybe society at large should pay. It would be great if we were a Medicaid expansion state. Medicaid does pay for these services in other states. So there are many of us, I'm not going to use the word lobby, but certainly advocating for that, for Medicaid expansion, and to help our colleagues or our friends and neighbors that are experiencing homelessness.
Thanks, Donna. Norbert, your thoughts?
Yes, and thank you for this question. I think this is an important one, and one that we really struggle with in this sense. We can see from a lot of research that has gone on that individuals who struggle with food security or food access issues, especially children, have negative health outcomes. Issues of behavior are also important for individuals struggling with food access issues. And those challenges can last and sort of have long tails and affect them into adulthood. And we know that's also true, and the connection between food access and obesity and other diet-related diseases are highly connected. And so we all benefit if we have a healthier society. Now, who pays the cost? And that gets into really political questions, but I think it's an important one. We all gain from it, and I think there is a role for us to provide that support. And the work of the SNAP program is an example where we see tax dollars are going to provide support to individuals in need. And the expansion of SNAP during the pandemic is an example of how people were able to actually do better. And maybe that's one of the reasons we saw some of the flattening out of the food insecurity rate between the 2 years. And so I think there's a role for everyone to participate. There is a real interesting challenge right now where people, and it's existed for a number of years, where people have argued, well, the charitable sector is the one that can solve the problem. And honestly, the charitable sector doesn't have the resources to do all that can be done. Charity is not going to solve the societal problems. It can play an important role, and it is an important way for us to connect, but it is going to take something much larger than that sector alone.
So you mentioned the pandemic, Norbert. Are there issues that created new ways of working that should be or could be sustained beyond the pandemic? And that's to any of you who'd like to address that.
I think the pandemic really shined a light on the fragility of our existence and life together. And the example I showed you about these micro pantries is just a small example of how community members saw a problem and addressed it. And the opportunity for us to continue doing that work, I think, will exist. And the fact that the government was able to respond through the various programs over 2 different administrations of different political orientations shows that there is an appetite and a need to do that work. So I look forward to seeing how both the federal government and state and local governments and community members are able to help fight problems that the pandemic has shown us that we can actually do something about.
I would say from the homeless perspective that the pandemic really highlighted for health systems the importance of being able to discharge people experiencing homelessness into a place where they could safely quarantine if they were COVID-19 positive. And so it's definitely strengthened our program's relationship with Duke Health. And I get to say that Duke Health is now helping support the program financially. And so very, very happy with that partnership.
Great. So to each of you, what is one action our audience members could take within their own communities to address the concerns we've discussed today? Hardy, do you have any thoughts on that?
I would say advocacy is probably the most important piece in advocacy, regardless of who's in the White House. But it seems to me that our country has a rich tradition of welcoming the stranger, and we have sort of wavered from that quite a bit lately. And again, this is not a political statement. And so I think reminding policymakers about how these individuals make our country stronger and better are important points for us to make. Otherwise, it becomes an issue of like a political football. And so I think advocacy on a local level, all politics are local, I do believe. So I think that's the main lesson I would put forward.
Advocacy. Thank you. What about you, Norbert? What are your thoughts?
I hope that the example I showed in my presentation is that anyone can actually do something small and provide support to their neighbor. So this example of the micro pantry is one, but I would argue that there are more important, not just more important, excuse me, there are other things that we can do to help. And I agree with the idea of advocacy because the problem of food insecurity is a challenge that many people face in our communities. Our neighbors may be the ones that are in need. And so advocating, even doing the small acts of providing food, and also I would encourage the use of our financial resources. Providing support to those who are engaged in this effort is an important way to provide support.
And Donna?
Just to really understand the issues, it's very important that people understand exactly what's going on and how this affects them. For instance, the increase in homelessness, there is an active hepatitis A outbreak in more than half of the United States that's been ongoing because of public defecation. Homeless people don't have bathrooms, so where are they going to use the restroom? This affects our entire society. So I would say understand these issues at a very personal level and get involved. Supporting organizations like the National Healthcare for the Homeless Council definitely is a great place. If you aren't individually personally involved, adding some financial support to those advocacy agencies is greatly needed and
well, as you indicated, these are complex issues, and we hope that by having presentations and discussions like these, and by sharing ideas and research, we can partner together to impact our own communities and society. I want to thank our panelists and participants for your thoughtful questions, insights, and engagement today. And with that, I'd like to turn it back to Jen.
Thank you so much, Stelfanie, and thank you so much for leading us in that Q&A at the end of the session. So much to think about, especially we end up another, I think, just unprecedented year. So with that, I will sign off. I did want to share with everyone the link to the YouTube channel where we have all of the sessions from this past year's Forever Learning Institute. So if you missed any one of the conversations that we've had this year, please feel free to jump onto to that site and you will be able to watch any of the recordings that we have of the previous sessions. We'll also be sending out an email later this week with a link back to this session if you would like to share it with any of your friends and family. Thank you so much for joining us today. And we will be announcing the new themes shortly in the Forever Learning newsletter. So look out for that in your inbox in January. With that, enjoy the rest of the year. Happy holiday days to everyone, and we will see you again in the future. Take care.